welcome. My name is John Berkman, and I want to welcome all of you tonight on behalf of Regis College and the Lupina Center for Spirituality, Healthcare, and Ethics. Some of you may not be familiar with the Lupina Center, which is relatively new here at Regis College. So please allow me to say a few words about that. The mission of the Lupina Center is to address fundamental questions at the intersection of spirituality, healthcare, and ethics. It is the conviction of the Lupina Center that for the true health of Canada, we must have a broader and more holistic conception of health, taking into account not only the current healthcare system, which is of course very important, but also beyond that, incorporating the social determinants of health, and as an integral part of that, the spiritual dimension of persons, and its role in a holistic vision of healthcare. Being a Jesuit college, we take seriously the Ignatian conception of spirituality, but the Lupina Center is committed to engaging and learning from other spiritual traditions, including but not exclusive to Christianity. We seek to engage in interreligious dialogue and learn from the wisdom of various religious traditions. Toward that end of the mission of the Lupina Center, it funds doctoral students working at the intersection of spirituality, healthcare, and ethics. It sponsors conferences and seminars pertinent to the mission of the Lupina Center, and as we have tonight, sponsors lectures. Tonight we are honored to have addressing us Sister Elizabeth Davis, who will speak on the topic of Reimagining Health in This New World, Transforming Canadian Healthcare. I now welcome forward Regis College's own Sister Jill Golding, who is an Associate Professor of Systematic Theology here at Regis, and also Chair of the Theology Department of the Toronto School of Theology, to introduce Sister Elizabeth. Dr. Golding.
Good evening. It's my great pleasure to introduce Sister Elizabeth Davis. I was saying to her before we came over that I think one of the most important things is that she used to live next door to me at Loreto College. Her other claim to fame of that kind of magnitude is that she's also one of our students here at Regis College. But above and beyond all that, perhaps what's more important perhaps for you to know is that Sister Elizabeth is also the congregational leader of the Sisters of Mercy of Newfoundland and Labrador. She has been involved in a variety of roles, particularly in the area of healthcare. These include being a member of the board of the Royal College of Physicians and Surgeons of Canada, being on the Canadian Health Service Research Foundation and the Medical Council of Canada. She's also been a member of the National Board of Medical Examiners of the United States and the Canadian Institute for Health Information and the faculty for Dalhousie University's Management Program for Clinical Leaders. So you can see her experience is vast and extensive beyond measure. She started life as a teacher and moved after nearly 20 years into a different field. Namely, she became the first president and chief executive officer of the Healthcare Corporation of St. John's. And in that very demanding role, in that very innovative role, she spent 6 years. She was one of the commissioners of the Royal Commission on Renewing and Strengthening Newfoundland and Labrador's Place in Canada. And amongst her other many achievements are 2 honorary doctorates and becoming a member of the Order of Canada. She said I wasn't to say too much else, so I think I'd better stop there. But it is with great pleasure that I introduce to you a great friend, both of myself and of Regis College, Sister Elizabeth Davis.
Thank you, Jill. It's quite intimidating to have the advanced degree director here, and I haven't got my thesis finished. So thank you for not saying that. It's also a joy for me to be back and for the first time to walk through the new location of Regis. When I left, we were still in the old location, so it's quite a beautiful setting and quite an elegant setting. I'm also glad to be connected with the Lupina Center. As I said to the Lupina Fellows this afternoon when we met, I feel very strongly that this center has the potential to be an incredible asset for the Canadian health system. And one of the reasons I said yes to John coming here was that I really, really, really want to emphasize how important that is. And you'll hear, as I make my comments, why I would even dare to suggest such a thing. So John and I talked about what I would present to you, and we talked about reimagining health in this new world. So I have four assumptions that are threaded through what I'm going to say. The first is that our world is changing dramatically. Sociologists tell us that we are seeing more intense social change than any other group of humans have ever experienced. Humans have always experienced major change, but for us it's happening in such a short period of time, so intensely. As a result of that, our understanding of health must change. It doesn't make any sense that it wouldn't change. And if our understanding of health is changing, then our health system must change. It's not changing fast enough, and we'll talk a little bit about that. But in order for it to change, each person in this room and all the persons who have invested interest in the health of Canadians need to lead the change, and I'll come back to that. So if you want to go to sleep now, I've said everything I'm going to say to you. Let's look at how our world is changing. I'm not a sociologist, but I have had some major emphasis in my life of trying to understand the bigger picture. One of the challenges we have in Canada around our healthcare system is that we focus on the healthcare system. And we really need to focus much more broadly in terms of this world that we're part of before we can even think about coming to the healthcare system. So why do sociologists say things are changing so dramatically? Well, again, a non-sociologist would put it this way. First of all, we're seeing demographic shifts. I was born 62 years ago. When I was born, Canada was a very young country, and university people at that time talked about the population pyramid. Very few people at the top, tons of people at the bottom. A beautiful pyramid. 62 years later, nobody could possibly talk about that. We have more and more people at the top, thank heavens. Sadly, fewer and fewer people at the bottom. And we're not a rectangle yet, as some parts of Europe are closely coming to, but we're coming close. We also have an experience that no other nation has ever experienced until now. We have 4 adult generations living at the same time, all formed with different values. That's unique. It's only new that we have that reality. Those in this gathering born before 1946, the elders, were born in the shadow of the First World War, the Depression, the Second World War, lived in the Second World War, and therefore are very convinced of the importance of stability, of hierarchy, of loyalty. My generation, and those in this room born between 46 and 65, were the famous baby boomers. We were born in a Canada that was becoming increasingly more affluent and putting a lot of that affluence into strengthening our social fabric. We have the distinction, even a sister like me who's part of the generation, of being the most selfish generation ever to walk on the face of the earth. The next generation after us, the Generation X, are a generation who experienced that interesting conundrum in their lives of seeing most of the mothers come out of the home and work outside the home, and some instability that brought, compounded with being the first group to have computers in their classrooms. So wealth of possibility, but some discomfort about shifting how the family should be. And then the new generation born since 1980, the millennial generation, are a generation that none of us can understand. They're going back to many of the values that the elder generation had in some ways. That generation is a mystery to most of us. Now, the challenge with all of this is each of these generations comes values differently. Now, I can't get it because I know the baby boomers have the best values. So I just can't get why the other three generations don't see it. One marker that's an easy one to understand about the difference in generations, the word boss. The elders generally think there should be bosses, they should tell people what to do, and they should be respected. Baby boomers think there should be bosses, they should be in charge, but we should have the right to criticize them. Generation X thinks there should be bosses, but you should be friends with each other. The millennials don't even know there's an English word called boss. And that tells you how the generations differ. In our society, we're seeing a shift in the role of women, but not quite as dramatic as those of us who were adults in the early 70s thought was going to happen. So we do have some major shifts, but we still have major glass ceilings that women cannot get beyond. Healthcare is a perfect example. 80% of the workers in the healthcare system in Canada are women. 15% of the CEOs in the healthcare system are women. There's an imbalance there that we cannot seem to break through no matter how much we try. And you only have to watch singers on television. Female singers, for some reason, have to be dressed in a very sexy fashion. Male singers can wear the dowdiest old clothes. Like, I don't get it. Why don't they make the male singers more sexy? I don't get it. The reality is we stereotype still. You watch 5 ads on television. Pick any moment, watch 5 ads, and see the depth of stereotyping that we're still allowing in this country, and I'll come back to that later in a few moments. Our church, the Roman Catholic Church that I'm part of, certainly doesn't understand that women are first-class citizens with men. And lately there have been several things that have happened that are really distressing to me as a woman that suggest our church is far from moving on this. So there are many fundamental institutions in our society that don't see that change. We also know the family in Canada is changing quite dramatically. We know now 60% of first unions among young people in Canada are common law. 60%, quite significantly high. We know there's an increase in lone parent families. 1 out of every 5 families in major cities in Canada now are lone parent families. And almost all mothers, although not solely. We have in this country, I think wisely, have families that are created with same-sex couples. And finally, we have more and more couples who choose not to have children. Almost close now to 50%. It's quite significant. We also know the face of religion is changing in this country. 85% of Canadians still on census forms indicate an affiliation with a certain religious body. Fewer than 20% of Canadians actually go to the church or the mosque or the synagogue. And Quebec, as you know, is even worse, the worst of all the provinces. Fewer than 15% actually still go to their religious services. And yet there seems to be a shift in wanting more spirituality, whatever that means. Doesn't certainly connect with religion as much anymore. Religious leaders no longer have much credibility and therefore much authority in the society. 25 years ago, even in Canada, if all the bishops of Canada had spoken to the Prime Minister of the day about a policy shift, they would have been listened to. When our government federally decided to approve same-sex marriages, all the bishops in Canada went, and it was made not an iota of difference, just an indicator of the shift. We're also seeing, so that's a major shift. The financial crisis, when I started in healthcare in the early 80s, every province in Canada was deeply in debt, as was the federal government. And we had crises then of not enough money. Then in the early 2000s, we had the crisis with the recession. This one that's happened in the last year and a half is different. In the first two, we had personal crises, we had corporate crises. In this one, we had personal crisis and corporate crisis, but also sovereign crises. So a country like Greece would declare bankruptcy. Countries like Spain and Ireland quite seriously impaired. That's what's new in this one. With every country on earth, we share a shift to cities, big cities. The move to urbanization from rural areas is quite significant. 80% of Europe, for example, is now urban. We are at probably, depends on how you define urban, but we're quite significant in Canada, probably getting close to 70%. That shift to big cities has two problems with it. One, the big cities are not well developed enough to hold the big numbers coming in. But even more tragic, I think, is the rural areas are being depleted of young people, of young families. And what we are doing in the health system is centralizing away from rural areas, a major challenge for us. We're also seeing in this country increasing cultural diversity in our big cities, not in rural Canada. As you know, Toronto has been designated as the most diverse city on earth culturally. More diverse than New York or London, Paris. Fascinating. 42% of people who live in Toronto were foreign born, not counting the Newfoundlanders. We probably draw close to 50. The impact of computerization. The computer is changing not only technically how we relate to each other, it's changing more fundamentally how we relate to each other. And we're noticing more and more among young adults and young people that the electronic communication is becoming the paradigm communication. I sit in the living room with my niece who's texting her boyfriend as she's talking to me, and in that interchange she's much closer to her boyfriend than she is to me, even though he could be 1,000 miles away. Interesting shift that's happening. The realities of violence in our lives. In Canada, we don't have much foreign terrorism causing us violence. We're seeing a decrease across the country in violent crimes in Canada. Where does most of the violence happen in Canada? The school, the church, and the home. The three places you would expect to be safest are the places in Canada where most crime happens, where most violence happens, where most abuse happens. And you know the majority of violent crime in Canada is family related. It's one of the tragedies of our time that we're becoming aware of the violence. There's probably no more violence, it's just we're more aware of it. And the most abused are the most vulnerable, logically. The children, younger children, spouses, almost all women, although not solely women, and more we're recognizing the extent of abuse of elders. As you know, there's an Elder Abuse Day now, an international day set aside to acknowledge that older people are being abused. We're also seeing major shifts in our focus on the health of the environment. That has all kinds of faces, but I just came from Newfoundland where we have experienced the ravages of Hurricane Igor. We know hurricanes are happening more frequently, more intensely, and we think that's related to things we're doing wrong. The impact on our oceans, there's several ocean nations in the Pacific that in 10 years will have disappeared because of, again, what we think are things we're doing. So we're seeing major shifts happening because of, forget the rightness of caring for Earth, the fact that we're not caring for Earth. One of the things our country, the United Kingdom, the United States, prided ourselves on is that after the Second World War, we worked very diligently in public policy to shrink the gap between the rich and the poor. And of all the countries on earth, Canada did it best. We got closer and closer. We had a very large middle class. We were just shrinking the gap quite considerably from the end of the Second World War well into the 1970s. And then by the mid-80s, that gap started to widen again. And today, the gap between the rich and the poor in Canada, in the United Kingdom, and the United States is wider than it was before the Second World War. And there's a wonderful image of that. The champagne glass from the United Nations. The top 20% of people on this earth, and we're in this room, we're in that top group, we hold 82.7% of the world's income. The lowest 20% of people on this earth, the poorest, hold 1.4% of the world's income. And if you put the top 40% together, we hold almost 85% of the earth's income, and the bottom 60% own less than 5%. Now there's 95, the top group own the 95%, the top 40%, and the lower 60% own less than 5%. Now you talk about something ethically wrong. That's the essence of ethically wrong because of all the connections that poverty has with, among other things, health. I think they were brilliant, though, in deeming it, using the metaphor of the champagne glass to illustrate that. Now, so that's a very quick synopsis of how I see some of the major social shifts in our earth, and therefore affecting us as persons. Out of that has come new thinking about what health means. Within all those social shifts, how do we understand health? And we have started to talk about the social determinants of health. In Canada, this is the Canadian list that comes from Health Canada. There are variants on this list, but it's pretty similar to this. We know, for probably some obvious reasons and some not, that there's a correlation between health and income and social status. By and large, when you look at large groups, wealthier people are healthier people. Now remember the champagne glass. It's not hard to figure out then where the healthier people are going to be. People who have strong social support networks are healthier. Correlation dead on, study after study after study, showing correlation between education and health status, employment and working conditions and health status, and so on. What's significant in all of this, one of the significant things in all of this, is that we have put all our attention to the healthcare system, which has very little to do with most of these social determinants of health. And we know in reality the health system has a lot less to do with how healthy Canadians are than the justice system, the employment system, the education system. And yet we put all the burden for the health of Canadians on the health system, which is, even if the health system were absolutely perfect, it would make very minimal difference in the health of Canadians. Another way of looking at these determinants of health, the same construct, your age, sex, hereditary factor, gender is a major health determinant, as you know. Here, then, the individual lifestyle, then our social and community networks, always broadening out to some of these other factors that I mentioned, and then the general conditions writ large. So same way, major shift in thinking, though, that's still more spoken about theoretically than lived out practically. Now, out of that is coming a new understanding of how we define health. When I began in healthcare, and I studied 400, 500 yards from here, I did my degree in health administration, we used the World Health Organization definition of health. Health is the absence of illness or injury. And we built in Canada the best healthcare system in the world following that definition. We built beautiful acute care hospitals right across this country. We brought in fine physicians right across this country. Our Medicare system, which, as you know, began officially in 1957 in Canada, was premised on health needing good physicians, and good hospitals. Now, with all the shifts that have happened in the last 50 years, that's no longer fundamentally so. Now the World Health Organization, slightly amended by me, by adding the word spiritual, describes health as a state of complete physical, emotional, social, and spiritual well-being, a resource for everyday living. Now, if that becomes the definition of health, our health system is certainly lacking, and we've talked through what that means. Some of the implications are that I, as a person, as a competent person, have the first responsibility for my own health. Not my physician, not the nurse who's tending me, but I do. And all of these other facts. But what's significant even more on that chart is the fact that its health is no longer just about the individual. The definition as an absence of illness or injury is always premised on the individual. And physicians are taught into their very bones that the most important thing for them is the physician-patient relationship, premised totally on health is about the individual. We know today health is about family. It's about family genetically. If my sister died with breast cancer, her physician told her that the chances of one of us, her siblings, getting breast cancer were quite high given the kind of cancer she has, genetic connection. I myself learned, sadly and tragically, that there are genetic connections related to certain forms of mental illness. So it's not just an individual. We all know about families that are totally dysfunctional, that do not have the kinds of social supports that families should be providing, correlated with poor health. We also know health around communities, living in healthy communities, however we define that. And there's a whole worldwide movement now to develop healthy communities, and they talk about everything from transportation to parklands to communities where both seniors and children feel safe. Populations, 2 little girls born in the hospital close to here. One has white parents, Canadian. She can expect to live to be 83 years old now, life expectancy of women in Canada. The little Aboriginal girl, born of Aboriginal parents, can expect to live to be 70 years old. Same country, same health system, same education system, theoretically same social support, two very different realities. And finally, and this is where we're not very good in the health system at all, but even in our church documents, talking about the health of earth and how intertwined that is with our health. Now just let's look at Canada vis-a-vis some other countries. And I've just taken a series of statistics here. Given health is written large now, let's look at it. When you look at student performance for countries around the world, Canada is third in mathematics, linguistics, those kinds of fundamental issues. We're in third place, pretty good if we're looking at our health. Child well-being, and this was only done in rich countries, we're 12th. Again, pretty good, I think. Quality of end of life, we're 5th. Level of gender equality, 31st. Health system ranking, this was a very controversial set of data released in the year 2000, 30th. But Human Development Index were 4th, and that's consistent over, as you can see, over 30 years. Water footprints were 115th out of 140. Not the place you want to be. Environmental performance were 12th. Now that's a misleading figure. Other indicators put us much lower than that. The greenest countries, 11th. What that says significantly is that we do real well on major areas except 2, gender equality and environmental realities. That's pretty sad in a country that has as much as we have. As you know, at our federal government level, proportion of women to men in our federal government system, elected officials, is also ranked 31. Now, we used to be 30 there until they set up the Iraqi Council, which has more women than men on it, women relative to men than we do in Canada. So I think it's pretty damning. Life expectancy, the real red bar, I don't know if you can see it, is the average. Average life expectancy in the OECD countries, that's the better off countries financially. The average is 79.1. You can see Canada's quite high there. Our average is 80.7. I'm talking about this side. On the other side, you see that broken down with males and females. Again, OECD 76.3 for men, whereas Canada is at 78.4. For women, 81.9, and Canada is at 83. And these are stats for 2007. So on life expectancy, we're actually doing well. Age is a significant one. The percentage of people over the age of 65. 65 is an artificial marker, of course. But in terms of older people, it's looking younger to me now that I'm getting closer to it. We're currently about 12% over 65. Look where we'll be in 2056. Almost 30% of our population will be over 65. Now, that's a good thing in terms of numbers of people. It's a frightening thing in terms of how we structure our community. But look where the shift starts to happen. 56 is the end point, but by 26, we're going to see significant changes. In Newfoundland alone, by the year 2021, we will double the percentage. We're now at 11.2% this year. In 2021, we will be 22.3% based on the factors we know about today. It's going to change our face, and then healthy cities are going to mean something very different. This is another version of the same thing, looking at numbers 2001, which is the green bars, that's real. And then there's the anticipated 2041. See how we're getting closer to that rectangle that they're starting to get to in Europe. That's the line drawing. We're seeing good results in dealing with illness and injury, acute illness and injury, because of all the technology, all the drugs, all the good hospitals, all the fine health professionals. But notice chronic disease, such as diabetes. Look where this is a percentage increase in the last number of years, the prevalence, in the last number of years. Canada is worse on that indicator than most of the other countries except two, the United States and Mexico. Look at our obesity numbers. Again, Canada, as you can see, is wants to move on me. It thinks I'm too embarrassed to look at the obesity numbers. But you can see we're quite close to the other shift. Oh, that's obesity. That's extreme overweight. Look where we are in terms of just being overweight. Canada is the black line there. And you see now, the good news is we're not getting as overweight as fast as everybody else is. So our curve is not as steep. But look where we are in terms of overweight rates in the country. Quite significant. And those numbers are pretty high. Canada right now, we have 50% of us overweight, and it's going to climb closer to 60% in the next 10 years. In other words, chronic illness is going to be the issue when we've built an acute care system around acute illness. Now, even within this system, there are vulnerable populations. And it's interesting when some of these are the ones you'd expect, Aboriginal people right across this country. Lower health status, incredible poverty and violence, lower life expectancy. Lone parents. 1 out of every 5, remember, families in many of our big cities are lone parents. Not surprisingly, a much significantly higher number of lone parents live in poor neighborhoods. Rural women, we can't explain this, but for some reason rural women in Canada have higher mortality rates. And then two groups you probably don't even think about. One is incarcerated persons. Unless you have a relative who's in prison, you never think about the health risks of being a prisoner, not just other risks. Exposure to HIV, antibiotic-resistant tuberculosis, major new scourge actually happening, Hep C, and sexually transmitted disease. And then most hidden group of high-risk people in our society are young women who have incredible, just talk about stereotyping, incredible social stressors that we're only starting to dare to name aloud. Now, in all the midst of it, so we have a changing social fabric, we have, as a result, changing understanding of health. And then what about our health system? Well, all health systems are created wherever they are, Peru, Japan, Canada. The primary purpose is to promote, restore, maintain health. Pretty straightforward. When we break that down, we're wanting to, in the health system, improve the health of the population, respond to people's expectations, and provide financial protection against the cost of ill health. So pretty straightforward. Every system in the world. What about Canada? Canada has a kind of a twist on that, in that we don't have one health system in Canada. We have 13. The BNA Act, which created us in 1867, said, we give the unimportant cheap stuff to the provinces, health, education, social welfare, and we'll keep the expensive, important stuff at the federal level, army, armed forces, and all those expensive things. So they sort of guessed wrong. Their visioning wasn't great in 1867 on that one point. So we actually have 13 independent health systems, each governed with the way they want to govern them, so with some significant funding from the federal government. We also have a national program that's of insurance that's federally dictated but provincially managed. We call it Medicare, short form. It's based on the Canada Health Act, which actually wasn't put in place for 20 years after Medicare came into being. And it's, as you know, the 5 key principles: public administration, comprehensiveness, universality, portability, and accessibility. The third thing about us is we have a $100 billion business called the health system in Canada. That's a lot of money, even by Canadian standards. So depending on how you look at that, you might see very different ways of understanding the health system. It is by far the most complex business in the world, whichever country you go into. It has, in education, for example, primary, secondary, elementary, high school education. In my province, we had 2 professions, teachers and bus drivers. Each knew their own territory and stayed out of the other. There are more disciplines, more work categories in the health system than in any other industry on earth. Professional, non-professional, clerical, every domain you can think of we have in the health system. The health system is run in people's homes, in people's communities, in hospitals, community hospitals, in tertiary care hospitals. The biggest one is within minutes walk from here, the University Health Network. It's run in offshore oil rigs, just all multiple settings, multiple sponsors, some federal money, some provincial, some private, some significant private actually, and of course all age groups. So quite complex. If you look at this, forget the health part, look at it as an industry, as a $100 billion business, it's quite significantly complex. Now, what diseases does our health system take most seriously? Well, it depends on how you define that. Is most seriously means it kills most of us? If that's the category, then cancer is the worst, followed pretty closely by heart disease, then strokes, then respiratory illness, and then accidents. That's overall in Canada. If, though, the marker is how many sick days you spend, how long you spend in hospital, that kind of thing, circulatory diseases actually are the most expensive. Cancer is next, then mental health, injuries, and digestive diseases. If it's the cost to the system, then you have a different layering. Cardiovascular is first, musculoskeletal, cancer, injuries, and respiratory disease. So still all pretty much in the same ballpark. How much money do we spend on healthcare in Canada? The OECD average is 8.9%. In other words, the kinds of countries that look like us in the world. We're not talking about poor countries here. We're talking about wealthy countries. So roughly 9% is the OECD average. Canada is just over 10%. And when I came in the health system, we were at 9.6%. So we've hovered pretty much around that same ballpark. Look where the United States is. Now, nearly every country of the OECD, except 2 or 3, have some form of public insurance as well as private. It's going to be interesting to see now what happens in the United States with Mr. Obama's new plan, which is far from even the least of these countries in terms of social insurance. But Canada is certainly among the top ones, which should have a higher ranking from 30th on that health system test. When you look at how the money is spent, we have a myth in Canada that we have a totally public system. Consistently in Canada for the past 30 years, we have a 70-30 split. 70% public, 30% private. You know, your own health care, your dental care, your eye care, your long-term care. If you're lucky enough to have cancer or heart disease, your care will be paid for by Medicare. You'll have your care happening in a hospital, and you will not pay you'll pay very little out of your pocket. If you're lucky enough to have dementia or Parkinson's, you'll pay for most of the cost yourself. And not talk about ethics, a quite unethical issue. The United States, on this one, obviously, and Mexico are the two that pay the least in terms of the public purse. Again, the OECD average is about 85%. Canada is slightly lower than that at 70%. There are two discrepancies in systems. We're talking about countries at large here. But in countries like the countries we're talking about, there's also a discrepancy. If you have above average income, in Canada, 7% say we're kept from getting care because of the financial burden. If you make below average income, 18% of Canadians believe they don't get their care met because of the financial burden. Now, the only good news with that is we're quite below most other countries, which is, if you compare us, for example, to the United States, where 52% of the low-income people say they're kept from getting care because of the cost. We don't look too bad. And the other discrepancy in Canada is where physicians are placed. Now, we, interestingly, have a lower number of physicians per 100,000 population than many OECD countries. But even within Canada, you can see the discrepancy in how physicians are distributed. There are more physicians in this city per population than there are in Northern Ontario per population. Quite significant. In terms of per 100,000, there's only 84 per 100,000 physicians in rural and remote areas, whereas there's 217 in Canada for urban areas. So it's within countries you have that same maldistribution you have across the country. Now, what do we citizens want in all of this? Remember, first is the health of the people. Second is the people's expectations. So what are our expectations? Well, I say every one of us wants to stay healthy as long as we can. If we get sick in any way, we want somebody there to be there for us. We're hoping that we'll get better and return to normal. If we don't get better, we're hoping somebody will help us through our chronic illness. And if we're dying, we hope we're allowed to die with dignity. So these are our general expectations. In 2001, an international panel developed, this was Europe and North America primarily, a very interesting listing of expectations citizens have. We have a right to health and health care, and that, by the way, is very Canadian language. We see a balance, though. We think I need to be taken care of when I have my heart attack, but we hope we have a system that makes more equity among the inequitable populations. We want comprehensive care, not just around illness, but everything from promotion to palliative care. We think the system should be cooperating with itself, a bit of a myth. We hope the health professions will work together. We do see, we recognize healthcare is a big industry that needs to constantly improve. We hope at the very least we'll be safe when we go to hospital. As you know, hospitals are one of the riskiest places to be from an illness point of view. And the last one is a dream still, that there's openness, honesty, openness certainly. I think there is honesty and trustworthiness in the system. Look at this poll, though, that came from Canada last month in August. The question was, if our system is no longer financially sustainable, what are we going to do about it? Canadians generally, almost 61% of Canadians think that we'd have a sustainable system if we managed it better. Such a naive, immature response that politicians have been drilling into our heads that somehow the system is managed so poorly, that's why it's not sustainable. 28% say we should put more money, tax dollars, into the system, and 11% say that people should be paying more privately from their own pockets. Now that 11% is pretty consistent. Survey after survey, some variation across the country, but generally Canadians want to keep the system we have, they just want it to be made more sustainable. So how is the system being responded to all of that? Like, is something happening that really is showing us the system is trying to correct? Many things have been happening. Some good and not so good. Government has begun since 1991, and we can trace it to that year actually. Government has begun to take much more control of the health system, with somehow the understanding they could do it better. The federal government interaction is a roller coaster. There's been very acrimonious relationships between the federal and provincial governments. The tension between the provincial having responsibility, the federal putting money in. That's been very much a roller coaster. For some reasons beyond my comprehension, the last couple of years, that hasn't been as dramatic a racket. Not because anybody's doing anything more wisely or we're getting better, but somehow I don't know what it is that seems to have toned down a bit. There has been a conscious attempt to balance the system better, to balance care in the home, care in the community, care in facilities. But I will tell you that I think we're doing better with care in the community. But care in the home, formal care brought into the home, home care, as we call it in this country, is often a way for the government to shift costs to family members. And it's quite tragic how poorly home care workers are still paid across this country, how much of the burden of care in the home is carried by family members without any recognition in tax law or any other kind of systematic look at the thing. Quite serious. On the institution side, long-term care is by far the poor second cousin. It gets nowhere near its fair share of money, resources, attention. It almost all goes to acute care, and particularly tertiary acute care. The involvement of clients in decisions, we're getting a little bit better, I think, at including people, but still not very good. We have restructured governance everywhere, even in Ontario, but the other provinces of Canada have all gone with regional structures, regional governance structures. Ontario has gone a different way with your LHINs, which are still quite weak in terms of the organizational component. We have more and more focus on outcomes and transparency, and a beginning of an acknowledgement of needing to include ethics. And one of the sad parts about our system is the increasing stress we're seeing on people who work in the system. So what do we need? What still haunts our system? Well, our health system is very far from understanding, incorporating, including health determinants. We're still looking at health care, fixing problems, rather than preventing them. Economics still is trumping quality, safety, and social determinants in terms of evaluation. The imbalance I've spoken to, we're still experimenting. You know, Ontario is experimenting strangely, I have to tell you, as an outsider, with LHINs. Alberta has done away with its regional structures and now has 2 master structures. PEI has gone with 1 master structure. So we're all experimenting still with what's the right governance structure. The stress is continuing to increase on people who work in the system. Positively, there have been calls for collaboration in practice, more evidence to inform decisions, better political will. But the one haunting thing, I believe, for our system is that we, the citizens, are not taking any responsibility for it. When you look at the church, I'm quoting here from the Canadian Conference of Catholic Bishops' letter in 2005 on Catholic health ministry. They put it this way: with growing financial constraints, government healthcare reforms, increased accountability demands, new technology issues, and bioethical issues at stake, Catholics must be creative to ensure that the Church's distinctive voice, presence, and mission are maintained in this important field of healthcare. And as you know, that's a major struggle across the country. So what kind of system do we want? This is how I will describe it. We want a health system which respects and protects the poorest and most vulnerable among us. We want a system that respects the physiological, psychological, spiritual, social, economic, and ecological dimensions of health, about Earth as well as about persons and communities. We want a system which endorses the contribution of other systems to the health of persons. We want to take advantage of the best there is in technology, but not at the cost of losing the personal. And we want to have a system that continues to struggle to find a balance for sustainability. Elizabeth Johnson, whom many of you know, talks about, in Catholic theologian from the States, talks about the 5 domains, 5 frontiers in the theology of God. Look how beautifully they map against everything I've said to you. She says the places we have left where we need to be in ministry: wretched poverty, women's experience of gender-based discrimination, white privilege and racism, religious pluralism, and awareness of Earth as a place of beauty, suffering in an evolving universe. These map very well against the health that I talk about. I'm just going to quote a couple of sentences from the bishop's message. They say the mission of caring for the sick is essential to the life of every Christian and of a just society. They're not saying it's only for some of us to be concerned about. And what are the hallmarks of Catholic health care? Deep respect for the dignity of each person, just and appropriate treatment afforded to everyone without distinction, spiritual and religious care, ongoing reflection on the ethical questions of the day, compassionate end-of-life care, and readiness to reach out to the vulnerable and sick in society who are frequently left behind. The one dimension they don't mention there is the ecological, which we haven't quite caught up to yet. When we look specifically at the formal health system, they say all hospitals and long-term care institutions should be beacons of hope, centers of warm welcome and excellence, where compassion, holistic care, ethical reflection, and faith-driven leadership are conspicuously evident. Now, what do I see as some hopeful signs, things happening that give me some hope even though I've been looking at this question now for almost 30 years. I do see greater awareness of health determinants. Nobody would give a talk like this without mentioning them today. I see many large entities in our system that are trying to shift our thinking, like the Health Council of Canada, professional associations, Accreditation Canada. I think new structures are emerging, not fast enough maybe. We have more money and more attention being paid on health services research. You just heard last week that major study that came out about whether we could be able to afford universal pharmacare. More attention on professionalism for the people who work in the system. Major commitments to quality and safety. The first ministers in 2003 and 2004 did come to significant agreements. Now, the bad news about that is, of course, the time is almost up for them. The system is responding more intentionally to calls for transparency, and there are champions out there. When Medicare came in, one man effectively was the champion, Tommy Douglas. Today we have many other champions. And we, as I said earlier, we're showing consistent support for keeping the kind of system that we have, what the fundamentals are. But what don't we have yet? Well, we do need increased patient participation in care for the individual here. We need better chronic care management, given that's going to be the burden of care into the future. We need improved access in those areas that are where they're not receiving appropriate care now, in remote and rural communities. We need to be much more sensitive to drug reactions and prescribing practices. We do need to reduce wait times, but not just for the ones who the federal government is putting money into. We do need to get that electronic health record finally in place, and we need to keep paying attention to quality and safety. But on the bigger picture, we do need to bring in some kind of social insurance for funding for long-term care. If your mother or your aunt or your father goes into long-term care today, they have to pay every cent until they run out of money, and then their old age pension will be paid almost totally for that care. That's unethical in our kind of system. We need to have a better system of home care where workers are truly valued and where we can somehow measure quality. We do need to bring in that universal pharmacare. Drugs today in Canada in the health system cost more than physicians. The money we pay for drugs is higher than the money we pay the physicians in Canada. They were both neck and neck at 15%, but drugs have finally outpaced the doctors in cost. We have to educate people differently, people who work in the system, initially and in an ongoing way. We need to pay more attention to evidence, real evidence, in the decisions we're making. But the last two are the two that I plead most strongly for, and why I think this Lupina Center can be a godsend for us. We need to have an accountable health system through democratic participation. Somehow we have to stop treating Canadian citizens like spoiled rich kids who get everything they want. It's not possible. Until we citizens come into the conversation, we're not going to be able to determine what is the health system that we're willing to fund and that we need. So we need to engage in adult conversations around citizen ownership of the system. Today, the system is driven either by politicians or by health professionals. And until we citizens are adults in that conversation, we have to take our own responsibility for not being adults. Until we're willing to take our place in that, we're never going to have the kind of system that we want. Now, this is not just a health system issue. There is, as you know, in the political language, a democratic deficit in our democratic countries, a divide between how citizens are engaged in decision-making. I was intrigued today when I read my alumna magazine from the University of Toronto. Janice Stein, in talking about the Monk Center, says The center has three responsibilities, three areas it wants to talk about: global economy, global institutions, and global civil society. And we're hearing more and more and more that term being used. What is civil society? She says it refers to the idea that volunteers, foundations, special interest groups, and individuals all have an increasing ability to band together to make change, irrespective of place and ethnicity, thanks in no small part to the internet. So that we are coming, because of this democratic deficit, we need to correct it. We need to correct it. And the health system in Canada is the largest and most blatant example of how we as citizens are content to take and to give nothing back. And the time has come for us to grow up and begin to do that. And finally, I end with a quote that's so important. It's both in the Old Testament and that rather insignificant appendage, the New Testament, repeated twice. In those last days, God declares, that I will pour out my Spirit on all flesh, and your sons and your daughters shall prophesy, and your young men shall see visions, and your old men shall dream dreams. Even upon my slaves, both men and women, in those days I will pour out my Spirit, and they shall prophesy. It's time we all, women and men, young and old, slaves and free, it's time all of us began to prophesy around this system that is so important to our lives as individuals, as families, as communities, and as a planet. Thank you very much.
Thank you very much, Sister Elizabeth, for that wonderful, informative, and inspiring presentation. Tonight we are also honored to have Sister Veronica Riley, CSJ, responding to Sister Elizabeth. Dr. O'Reilly is the Sister of St. Joseph, and for the last 7 years, up until this last year, was the Executive Director of the Federation of the Sisters of St. Joseph. Dr. O'Reilly earned her PhD in English from the University of Toronto and worked for many years in education. She has also been a leader in the Ecumenical Forum in Toronto and worked in the area of ecumenical affairs for the Canadian Council of Catholic Bishops. More recently, she has been busy writing a history of healthcare and social services in Canada, focusing on the role of Catholic religious orders in that. Dr. O'Reilly has shown leadership in many areas of Canadian society, having served on the board of directors of Ontario hospitals, universities, and our own Toronto School of Theology. Dr. O'Reilly has been variously honored for her work, having received honorary doctorates, been made an honorary fellow of the University of St. Michael's College, received the Order of Ontario, and the Queen's Jubilee Medal. Last but not least, I am extraordinarily grateful to Sister Veronica for having agreed to respond to Sister Elizabeth at the last minute. We had another respondent lined up, and that respondent had to bow out, and Sister Veronica has graciously stepped into the breach. So we are doubly grateful and honored to have her with us tonight, and I now welcome Sister Veronica to respond to Sister Elizabeth.
Well, thank you, John, for that very kind introduction. You know, being a respondent, even the last-minute substitute, is not at all a bad thing. To paraphrase Homer, next to being brilliant, the best thing is being able to quote someone else's brilliance. And it is indeed a very great privilege to share even briefly in your enthusiastic response to Elizabeth's brilliant presentation this evening. Interestingly, Elizabeth has chosen to end her presentation with the poetry of the Book of Joel. This prophetic work, as you know, is highlighted by a couple of significant events: the invasion of locusts and the creative, visionary outpouring of the Holy Spirit. Now, if it's true, as Oscar Wilde has said, that the critic has to educate the public and the artist has to educate the critic, then I think this biblical motif is particularly apt. Tonight's presentation dissects accurately and in detail the momentous issues at hand in Canada and across the world regarding the well-being of humanity in general, and in particular those various and fragmented sectors of public health service. As she does this, Elizabeth also holds up for us the related issues of our planet's battered resources, the regional disparities, the gender issues, and the philosophical differences. I staggered a little under those statistics from the OECD and was thinking again of Oscar as I listened, because he said one time it's a very sad thing that nowadays there's so little useless information. And dear God, that was all so vital and so challenging. And yet the artist was there in the critique, because it was not only a comprehensive and hope-filled vision, but it pointed out to us what healthcare can be and really is in the process of becoming. We're not left with an entirely dark and dire picture. It's not all locus. For we've seen in Elizabeth's presentation the evolution of national and international definitions of well-being that are inspirational, aspirational, and happily operative in many venues and through many agencies. We have evidence of some limited citizen participation and expectation, and importantly, we are called to celebrate the affirmative orthodoxy, as John Allen goes round saying these days, of a faith tradition that at its best respects life and the abundance of it, and that insists upon our moral agency as creative free citizens who can make choices for even greater life for all people. But if I had to subtitle Elizabeth's paper, I think I might call it Naming the Gap: How the World Has Changed and Most of Our Systems Are Still Playing Catch-Up. Because Elizabeth's her comments, I believe, are genuinely prophetic. She names our reality, she judges it, very Old Testament that, Elizabeth, and she points in the direction of the dialogue, the conversations that will move the enterprise of catching up, that will move it to healthier places. Now, there's really nothing I could add to that was said tonight, but I would like to just offer a couple of very brief comments and raise a couple of questions perhaps on our own engagement with this issue, with the justness of this issue, with this enterprise which, as the Bishop's pastorals keep reminding us, is constitutive of our very identity as Catholic Christians. Maybe a few comments too on the context in which we are now making our choices, whether we're healthcare practitioners of any and all stripes, or theologians, students, politicians, farmers, teachers, bankers, citizens of this planet, who need the care and the freedom that a healthy world can provide. In doing some research on the history of Catholic healthcare in this country, I was struck by two interesting comments made by two retired and renowned hospital CEOs who are now retired, both of whom happen to be vowed religious women. One of them, Margaret Smith, was asked if she would say a few words at the opening of the new public hospital in North Bay. This is a facility which is replacing the former public and the Catholic institution, a scenario that many of us are quite familiar with. And of all the things that Margaret might have said, and she's sort of given to saying a good deal, she decided to just say quite briefly something about the fact that she would hope that the sisters had left at least some small legacy to those who follow in providing health care to the people of the area. Over the years, our desire to provide the best medical care possible, she said, has always been infused with a vision of the ultimate dignity of the human person as they are born, as they journey through life, and as they die. Whatever tenderness, discipline, and professionalism our religious community has offered has always been infused with this vision. My hope is that in some way we have passed this vision on to those who now follow us. The second woman said to me in a private conversation, "I don't really regret the loss of our hospitals because it was becoming impossible to provide the kind of care we have always tried to give." Now, circling around these two remarks, I believe, is a new story that has been developing for us as Catholic Christians and as citizens of the world. As Elizabeth said at the outset this evening, and as we have been aware for many decades, our world is changing dramatically and at speed. And if, as popular wisdom has it, there are few trusted meta-narratives or caravans of traditional culture and belief to transport us across the looming deserts of transmodernity, then we need to be alert to the emergence of new or radically new stories, radically renewed stories, stories that express our faith tradition in new and fresh ways, stories that will give both meaning and energy and best truth available to our efforts, to make all our efforts for the well-being of our world, particularly the healthcare world in this case. For it is within that new narrative, it's within it, that we will need to find our way forward into the best healthcare possible for our country and for our world, and into the best positive systems of economics, of teaching, of health policy, of education. So at a gathering such as this tonight, I can't see you all, but I'm pretty sure, there's no need to elaborate on what I mean by a new story. It represents one of those leaps in consciousness that our species occasionally takes. Perhaps brought about by science, scientific discoveries, heightened awareness of personal and communal experience, evolving biblical studies, and I think an acceleration of technological miracles, which really alters, as Elizabeth has said, our very reality, and possibly through the inspiration of the Holy Spirit. I want to highlight only an element, really, of this narrative that seems to be emerging, because I think it demands of us a conversion that is deeper than may at first appear. Key to the thing is the necessity of accepting philosophically, scientifically, theologically, and in everyday praxis the fact of our fundamental connectedness to one another and all of creation, and the everyday gritty ramifications of that fact. In this morning's Globe, Charles Taylor writes of the struggle to make democratic societies work. And I quote, with some trepidation, I quote Charles Taylor, even in context. He writes that solidarity is essential to society, and all our efforts will founder unless we refuse to dismiss outright the people and ideas that differ from our own. Our societies, he says, will hold together only if we talk to each other with openness and frankness, and in so doing, we create a certain sense of intense solidarity from all our different roots. The challenge nowadays, he said, is to maintain that sense of intense solidarity from all our different roots. And, Taylor adds interestingly, faith traditions have a place at that table. In somewhat the same vein, an undergraduate classmate of mine at Trent many years ago, and now a prolific exponent of paradigm shifts of our time, Don Tapscott, writes in his latest book that the eloquent efforts of European leaders like President Sarkozy at the Economic Summit, of the Copenhagen Conference on the Environment, will fail to right either the economic woes of the world or the problems of climate change because, as Tapscott says, they harbor the same tired old set of assumptions about how to solve the world's problems. If our problems are global in scale, he says, then we need to come together as global citizens to solve them, as Janet Stein is saying. He also says that a system erected around the primacy of national and corporate self-interest just isn't going to cut it for this century. And I find it interesting that he puts forward, in his new book with Tony Williams, he puts forward as a way forward in this deepening of the conversation and the dialogue among ourselves and with the other, that a good thing to do would be to sort of call in all of the folks who are operating on the social networks and bring them together across the world as part of deepening the conversation and involve them in that. And he said, of course, it would mean crossing national boundaries, crossing state boundaries, crossing corporate interest boundaries, and so on. But it's a very interesting thing. So, personally, I find the challenge that Elizabeth poses for all of us, the challenge of open, participatory dialogue with the other in order to move forward the common enterprise, I find it very, very difficult. Even while my better angels tell me that it's essential if we are to move into a world which no longer expresses in its system what Thomas Berry has called a deep rage against our human condition. I find it difficult because, like charity, this one begins at home. In my sexism, in my racism, in the dichotomies in my thinking and in my language, in my laziness about making the sort of the connections between and among all things, in my failures to opt for pluralism. You know, Brian Massingale, who's an African-American priest from the United States, told a group of very dedicated religious women a couple of years ago, "Your moral outrage bores me." I think a not-so-gentle way, perhaps, of reminding us that our mission statements, need to be backed up by very active, the creation of structures and policies that favor organic and fluid interactions, that endorse networking and coalitions. I take hope, in spite of the difficulty that it poses for me, I take hope from my own faith tradition, from its incarnate transforming energy, and from the compassionate love of a community of fellow travelers. So I suppose I would leave you, if I might be permitted, with the question, how are you doing in the business of building a new story for the new world? Now, it's very, very bad literary form to end one's comments with a poem. And so I apologize in advance to my mentors, deceased and otherwise, who taught me that. But I do want to close with a poem, because I'd like to dedicate it to Elizabeth, and I would like to dedicate it to all of you who will see visions, dream dreams, and by your lives will prophesy. This is Judy Chicago's tribute to Joel and his Day of the Lord. And then all that has divided us will merge. And then compassion will be wedded to power. And then softness will come to a world that is often hard and unkind. And then both women and men will be gentle. And then both men and women will be strong. And then no other person will be subject to another's will. And then all will be rich and varied. And then all will share equally in the earth's abundance. And then all will care for the sick and the weak and the old. And then all will nourish the young. And then all will cherish life's creatures. And then all will live in harmony with each other and the earth. And then everywhere will be called Eden once again. Thank you.
Thank you very much, Veronica. And now we have some time for if people have questions or comments they'd like to make to Mr. Veronica and or Mr. Lee.
You like my candle?
I'm hearing a lot in my career with mental health care, and I'm hearing a lot of language that I learned much, but also in response to health care, and very pleased about some things that he's able to receive. But I hear a lot in the language about this is the sort of last result, that those sorts of things, how funding and care, about a lot of negative language. And not sort of the minimal and the negative and that kind of language, and where it's and where it leads us, and just sort of looking at maybe what do you think is the way forward from here?
What you're seeing is a new phenomenon, relatively new phenomenon in that, and that's why I talk about so much the stress on workers in the system. They've reached the point now where that's how they respond. They say we can't do anything else, or the administrator or the government or whomever, go to your newspaper, go to your member. There's a lot of that reaction to stress that's come on the health system, and I think that workers in the health system are really dedicated people who really have come into health care because they want to make a difference. But they're tired now. They're tired. Their psyches are tired because of the way society is not conversing with them, the way governments are not conversing with them, and the way they turn sometimes on each other, blaming each other. Mental health is one of the more vulnerable areas. I was not happy with the decision around wait times, which all focused on hips and knees and hearts and cancer, and we're not focusing on mental health care and wait times in those areas. So that's a particularly challenging part of the system, and remains so. I think the question of how do you get past that comes back to my fundamental point, which Veronica more beautifully than I expressed, and that is until we find new ways to have these conversations with adults talking to adults, not doctors talking to patients or nurses talking to patients, but all of us having those conversations in a way that's nurturing each to the other. Until that begins to happen, I don't see how we're going to get out of this. What's heartening to me is even groups like the CMA and major unions across the country are finally also starting to talk in those terms. But still at a very specific level, we're seeing too much of the other.
Well, I wonder if in some ways we're still sort of doing hand-tying, like specifically with mental health, perhaps around things like privacy. How are we supposed to be communal and communicate and families, healthcare, but also agencies, if more and more limitations and obstacles or enemies is brought.
Yes. And that's really challenging. Privacy legislation in this country, again, is provincial, as you know, but the privacy commissions across the country have been so appalled by the lack of confidentiality that in a normal human fashion we've gone to the other extreme now. And nothing can be broken, no confidence can be broken. In my role as congregational leader, I have several sisters who are now getting dementia. Like how to deal, even someone like me who knows that system in Newfoundland inside out and who is known by the practitioners in that system, how do I, as the responsible agent in many ways for these women, how do I get to relate? Like, it's so challenging, and very often I find myself shaming those sisters into giving me permission to talk to the physician, and that's horrible. Everybody is disrespected in that whole thing. But because we were so far wrong the other way, that it's a corrective that we're building in. And I have some hope around the privacy stuff that we will get back to some kind of balance where the ones who need to know do know, and then together we're finding solutions that we're never finding separately. It's challenging in all areas, but mental health, dementias, those kinds of illnesses where competency is not quite gone, but is not quite complete. It's becoming more. It's really, really hurting us there. But the alternative that we were doing before was equally wrong. We were dismissing people, treating them all as if they were incompetent. I remember on a trip to China, a group of us were invited to go in the mid-90s as China was starting to come into this new world that's now pretty much beginning to dominate. The Chinese Medical Association brought us practitioners of ethics and ethicists, a combination to them, about 40 of us. And they told us that when, at that point, the moment you went into hospital, you were deemed to be incompetent. Like even if you went in with a broken leg or cancer, you were deemed to be incompetent, and the decisions were made between the health professional and the family. So we were all suitably appalled by this until it dawned on us. That's what we do all surreptitiously. You know, if a father, a man who's quite competent but elderly, has been diagnosed with a terminal illness, and he has a daughter who's a nurse, the doctor will always talk to the daughter first, not to the man. I said, you know, we were appalled at this terrible situation, but at least they were honest about it. So it's, you know, assumptions are things you don't know you have. Like how do we get past that? It is quite a challenge. Finding the balance is quite a challenge. I get a sense the privacy stuff has gone as far in the other extreme as it will go now, and I see some moving back to a more sensible place for it. I don't know, Kelly, that answers the question. At least it reflects on what you're saying as real.
So I'd like to push some of the lines I think you're going in the presentation. I mean, I think you beautifully laid out. We built a wonderful healthcare system based on a model of health that's 45 years old, and our understanding of health has changed, the demographics of our country has changed, and we need to redirect all the resources we have in directions that we have not directed them to in the past. The driving logic of that then means that we need to withdraw significant sums of money from certain parts of the healthcare superstructure as it was built 45 years ago. And of course, nobody wants to see that happen. But I'm not asking you to make specific cuts, but what are those aspects you think that have been, in some sense, overfunded, recognizing that we have limited funding?
You remember my healthcare experiences as an acute care administrator. So I fought for 15 years to get every cent of money I could get out of our government for acute care and tertiary care, and felt justified in every bit of it. And if they had said to me, we're taking 1/3 of your budget and putting it into Aboriginal health in Labrador, I would have gone absolutely wild. So, you know, I don't want to, was it Mark Twain who said, to be good is noble. To tell others to be good is even more noble and a lot less trouble. So I'm very conscious here that I'm speaking against my life experience. That's why I think we need to have a conversation. We're pretty much now in almost every province at 40% of the provincial budgets going into healthcare. Now, a lot of that's coming from the federal government, probably 18% is from the federal government. So no economy can sustain much more than that. That seems like pretty blatant reality. Unless, you know, I think we could easily spend 100% of our budget. So that's not the way it's going to work. Now we have long-term care where the burden is borne by the person, the financial burden is borne by the person. We have unaddressed areas like Aboriginal health, mental health, under-addressed, and they need resources. And they're more intensive human resources. Acute care has gone very high-tech, high pharmaceutical. So it's a terrible dilemma. we could trust the government to do it on our behalf. The way government and democracy is going, that makes me shudder. We could trust health professionals to do it, but they will do what I did. I was a really good health professional. Like I pushed every button as better than many to get what I felt we needed for acute care. That's what I was paid to do. So therefore, it seems to me, it keeps coming back to this question of the conversation. We could go the way the Americans have gone, which is very much individual driven, except it will cost twice as much as it now costs us. We have the facts on that reality. We could go the way Britain has gone, which is much more controlled, but they make our waiting lists look like jokes, you know, and they're asking ethical questions about cut age limits on when you give certain interventions. It seems, but we also know the most money we spend, even in acute care, is on the last 6 months of a person's life. So we're forcing terribly disrespectful situations of persons where care is actually futile, that are in ICUs with tubes from everywhere. You know, so we have a whole lot of imbalances, I suppose, think for a better word. But the only way out of that, I think, is back to conversations of adults. We have not done that in Canada. Nowhere else in the world either. So that complicates it. But we haven't found a way to have a mature, citizen-based conversation about this. Romano tried it. He really did. He brought in the best at doing it, but still it was white middle class, most who worked in the health system, who had input. So I don't know how we're going to do this, but I know we're going to do it because we have no alternative. Going the American way is worse financially. Forget about anything else. It's worse financially. Going the British way is not a way that we tolerate culturally. So I don't think we have a choice. Now, how do we get our public media, for example, to let us engage in that kind of conversation? We haven't found any answers to that. But there are some signs of groups and individuals who are beginning to push it. But I think, and I've said it, and I say it everywhere in Canada, much to people's chagrin, I do not believe our healthcare system is in crisis the way we define crisis today. I think it needs transformation. There are healthy signs the transformation is happening. I think our universities actually are worse off. There are less healthy signs. Universities are going in the right direction, in my view, being a doctoral student and all. But I do think there are some signs of hope. But we're talking a generation of change here. But putting it in the bigger context is critical. To think we can handle the healthcare system as if it's some kind of a discrete entity over here has nothing to do with all that other stuff going on. It's just so insane, you know. So putting it back in the larger context and then having those conversations of citizens, the civil society that Janice Stein and those talk about, I think it's the only way we're going to have that good health system we need.
I appreciate the contextualization you're giving and also the area you're rolling out to these citizens, these institutions, or people. If you put the mirror specifically on big communities, and you make the program assessment in terms of church credibility, 100 bishops knows it all. And the church has missed an ecological focus on this. If we are going to rewrite the narrative together, and so that we'll do that, either what does the church leadership or us as a church do differently, or what's the story we keep saying that's getting in the way?
That's obviously way bigger than healthcare, that question. Again, those signs of hope. You know, the bishop's message of 2005, it was vaguer than I would have liked and not as advanced beyond where we were in 1983 than I would like. But it was a sign that bishops were serious about, and that was written primarily about a fear of Medicare being destroyed as well, I think. One of the, 85% of Canadians still affiliate themselves by their own choice, even if they don't go to church, with a church or a religious tradition. So there's still something that we know that there is in faith traditions a deepness that we don't get in ordinary other kinds of realities. So despite the fact that churches are failing the citizens and their members, there still is a deep hunger for that kind of connection. Now, I rant and rail about this in my other life as a religious leader with the bishops about the church needing to come into the 21st century. And whereas I see too many signs is actually going back into the 15th century in some cases. But, even though the credibility is being lost, like groups like the Medical Council of Canada will still make a nun their president. Now, why would they want to do that? She's not even a doctor. They put me as president. And it's not because I'm that brilliant. I mean, I'd like to think so, but I know they see that I had stood for a values base that was beyond me, that they want to get into medical education. So they were using me, and I knew they were, but I was willing to be used because it suited my purposes to start sending some messages. The Caribbean schools were looking at accreditation on the Canadian and American standards, and they asked me, the Americans asked me would I chair the session, and I said, no, I don't know anything. I'm not a physician. I don't know anything about this. They said, but we want somebody whose very name, meaning sister, that stands for something that they won't trust us to produce. Very interesting, So they're not people who are probably churchgoers at all. But they'd write on their census form, they're affiliated with some church. So there's still a deep yearning for the kind of nurturing that faith-based traditions bring. The status of women groups at home are very far left philosophically, very far left, quite dramatically left. But I'm one of the people they love to talk to them about the Bible. Now you want to talk about the exact opposite spectrum, but because they know that book is so powerful, that is their way of interpreting it into their culture that nurtures them. Like, this is pretty deep, fundamental stuff. So the yearning is there, good news. We have so much resource over so many centuries, good news. We have a God who promises, I don't care if you're young or old or women or men, no odds to me. I'm giving you this Spirit, whether you want it or not, and I'm pouring it out. So all of that is in our favor. I don't know when we're going to get it, though, as the official church. But, the gospel most people will read as you, not the Gospel of John. So we have to keep remembering that, too. So those of us who do have the privilege of still being connected really and truly to a faith-based tradition, still valuing it, still being nurtured by it, maybe it's our lives that will make others who have that same yearning you and I have, but haven't had the privilege we've had perhaps to be kept inside the fold somehow. I think that's where it's got to be. Back, though, to conversations that respect what Veronica said so beautifully, the other's viewpoint. Whether the other is different from me in sexual orientation, or different from me in color, or different from me in the way we pronounce English. All kinds of differences that we hold as so divisive. I told a story this afternoon. I was on a panel with a Norwegian minister, and he was from Stavanger in Norway, and I said in my very gracious, welcoming comments, how much we have in common, how linked we are. We're simply divided by the Atlantic Ocean. And he got up and spoke after me and said, I want to correct one thing Sister said. We're not divided by the Atlantic Ocean. We're connected by the Atlantic Ocean. It was one of those defining moments in my life about what you see as division and what you see as connection. And maybe that which divides us is in actual fact that which truly connects us. And how do you get to challenge people to see that? I think that's why the Lupina Center, to me, is one of the gifts, could be potentially one of the gifts to this country, of being able to do that, of being a credible place where we discuss these issues. We're not in the system, so we're not caught in the urgency of the system. we're able to discuss thoughtfully and openly and compassionately and bring in others, other viewpoints, other perspectives that seem to us even maybe totally other, I've always said that when I create teams around me, I don't want people who think like me. I know how I think. I want people who don't think like me if I'm ever going to look like a good leader. So it's a long answer, but I struggle with this question. Why do I stay a nun in a church that doesn't have a lot of time for women, and then choose to agree to be a religious leader in that church? Like there's something seriously wrong with me. But this church, I love it too much to let the other pieces of it keep me from being nurtured by the faith tradition I'm blessed to be part of.
Okay, one more question. I've been quite dismayed by the discussions going on in the province of Quebec over suicide. Now, I'm told that one of the reasons why those discussions are still alive in that province and not very alive in the rest of Canada is because there isn't the provision for palliative care. And so, what's informing moral decisions is the medical system that hasn't seen it with the use of funds to provide palliative care that relieves the suffering. So if people can't get any relief for all their pain, they'll say, well, gee, I was kinder to my dog than I am to my husband. And so they opt for palliative care. And so somehow the medical system, with however they allot money, is influencing the moral decisions of individuals. Could you comment on that?
You're right that its conversation is more pronounced in Quebec. You're wrong, I think, in determining the reason for that, or interpreting the reason for that. Palliative care in this country began in Quebec. Dr. Balfour at McGill was the first one to bring a palliative care unit focused. So they have palliative care units. Palliative care is very poorly funded right across the country, and very poorly valued right across the country. Sharon Carstairs, as you know, has made that her life mission in the Senate to try to reverse that. But we'd be wrong to think in this province that you have a lot of resource going into palliative care. It's underfunded, but even more sadly undervalued, partly because of how we educate physicians. We talk about physicians as healers, and we value them best when they save lives. But as Daniel Callahan said in the States, in the battle between medicine and death, death will always win. So we have a psyche problem here, right, culturally, that palliative care equals failure. So that's the one issue. Quebec in Canada is always the bell ringer. When you look at it from a healthcare perspective, in healthcare, Quebec is always the first out the gate. The rest of us generally are 10 years behind. So what saddens me is I know that conversation which is starting in Quebec is going to go to the rest of our provinces. And you're going to get more and more, all the surveys now that the Ipsos Reads of the world are doing are showing more people across the country, not just in Quebec, actually saying, I don't want to be kept alive to suffer like that. So the failure is partly cultural in that we have a culture that sees old age and death as the worst of all. We idolize youth. We spend billions and billions and billions of dollars on staying young, and we devalue people who are older, women more than men, but even men as well. We certainly devalue people who get dementias and those kinds of illnesses as they get older. And nobody challenges that in the system. So that's one problem. The second problem then is we have that healthcare system that worshipped acute care since the beginning, since 57. So to try to make that a more broad system that truly values long-term care, that recognizes chronic illnesses, and that truly values palliative care is a health system issue that comes out of society. And then we have such little resource in research going into palliative care, so that there is less pain for those illnesses that cause so much pain. And finally, our faith traditions who've talked about the difference between pain and suffering, we haven't found a way to have those conversations more clearly either. So it's really a complex problem with all kinds of multifacets to it. I don't think Quebec is not their health system that's causing it to come more to the fore in Quebec. It's Quebec generally is ahead in the thinking on those things, and the rest of us will follow, which is tragic. When we in Newfoundland were developing an agreement with government about our Catholic hospital, we appended the principles, ethical principles. And when I went to the Minister of Justice, who was a good Anglican, to ask him, was this acceptable? He said, "I can't believe it, Elizabeth. You've left out the most important thing." And I said, "What?" I thought, "Oh, I'm losing it all here now, I can tell." He said, "Why haven't you got anything in about advanced health directives? Why haven't you got anything in there about that which you worked on with me on the Law Commission to make sure people have ways when they're becoming incompetent to help them deal with that, help give decision-making to the person who shares their values?" So we have so many issues around that we haven't reconciled. But if I were a betting person, 5 to 7 years' time, we're going to have physician-assisted legislation of some kind in this country, allowing more than we allow today in that regard. And the sad part is the Catholic tradition, which is hopeless around ethics around reproduction, is actually hope-filled around ethics around end of life, and we don't talk enough about it.
Mr. Liz, you've given us an incredible amount of food for thought this evening. Thank you so much for your wise comments and reflections and prophetic support to it.
Thank you, John.
And thank you, Mr. Veronica, as well, for your comments. And the two of you together have given us a wonderful evening, and for that we are so grateful.
Thank you. And I really can't end, John, without saying that I want you to make sure that this Lupina Center truly integrates itself, not just into the Catholic system, but into the health system right across this country, because you have the potential to be a gift of immeasurable worth if you do that. And I really, really challenge you to do that.
Thank you. We're definitely going to do our best to do that. I want to make two quick announcements towards that much larger goal. One is the Lupina Center has also scholarships worth up to $40,000 for doctors who want to do doctor work here at Regis on that intersection of questions of spirituality and healthcare network. So I encourage you all to spread the word on that. And secondly, we have our big Lupina conference coming up in 2 weeks' time. It'll be on Friday, October the 15th, and Saturday, October the 16th. We have, I believe we're down to 16 different speakers, panelists, respondents coming from all of the United States, United Kingdom, as well as Canada, to address the question of medicine as a spiritual practice toward a holistic public health care. So I encourage you all, if you can make it to that conference in 2 weeks' time, and invite others to come as well. We have a little reception, so please continue conversation over some drinks and food, and the next room over there is also coffee. So please continue to make yourself welcome here, and continue the conversation that has been so wonderfully able to be done by our two speakers today. Thank you all very much.